Good day, everybody. Thank you for joining our webinar today, which is focusing specifically on the recent release of the World Health Organization of the risk reduction guidelines for dementia. I am delighted to welcome you here. We have a very varied audience today. We've had hundreds of people saying that they would participate, so we will be very interested and keen, as well as the questions we have received before the webinar, to also hear your questions during the webinar. You are all going to be muted, apart from the speakers, and you will be able to communicate with us through our chat line. Please be aware that this is a live session and is being recorded. We will eventually put it on our website for reference of all of those that, due to time zones or difficulties, have not been able to participate. Now, let me introduce you my fellow speakers today. Just making sure that you know that all of the people talking at the seminars have been active and enthusiastic contributors to the risk reduction guidelines that the WHO has produced recently. So the first person on my panel and the first person to speak will be Neerja Chowdhary, who is the technical officer in the Department of Mental Health and Substance Abuse at the World Health Organization. And Neerja is a psychiatrist by training. The second person that will speak is going to be Professor Karin Anstey, who is the Senior Principal Research Scientist at Neuroscience Research Australia, Neerja. We also have to thank Karin, especially since it's 9 p.m. in Australia, and she has made it on a Friday at 9 p.m. To the webinar. And you can see the level of commitment of all the people that have produced this report in trying to make sure that as many people as possible know the great amount of information contained in it. The third speaker today is going to be Professor Mia Kivipelto, who is a professor in clinical geriatrics at the Karolinska Institute and a senior geriatrician at Karolinska University Hospital in Stockholm. Mia will be known to many of you because she is the person that invented the finger studies, which is one of the biggest risk reduction clinical trials that is in the world today. Last but not least, a board member of ADI, the chair, CEO, and co-founder of Dementia Alliance International, Kate Swaffer, and one of the most active contributors to this very important report. Now, let me start by showing you one particular slide, which is the Alzheimer Disease International specific contribution to the risk reduction debate so far. So let me see if we can share the slides with you. Can we?
Yes.
You got it. So we have produced in 2014 a World Alzheimer report, which at the time contained all the latest information about risk reduction. Subsequently, The Lancet published a review around risk reduction a couple of years ago. And the report that the WHO publishes today is, we can say very easily now, is the definitive guide to everything that we know now around risk reduction in dementia. One of the reasons why we are doing this webinar is also that many of our members use the second thing you can see on this slide, which is an infographic on how can we reduce the risk. Many of you will be familiar with this infographic. It has been used for years, and there are a number of things that may require change following the new guidelines. So this is something I am very interested in exploring, as it's a very simple infographic, very impactful, but if we need to change it or expand on it for it to be a little bit clearer, this will be a very good and important time for us to do that. Now, let me pass to the actual substance of our webinar and ask Dr. Chowdhary to start by telling us why the new risk reduction guidelines are so important. Please, Neerja.
Thank you, Paola, and hello, everyone. Thank you for joining us, and thank you for this opportunity for me to present on behalf of the dementia team at WHO. the new dementia risk reduction guidelines. Can I have the next slide, please? Thank you. We are all aware of the increasing global public health threat of dementia. We know that by 2050, there are 152 million people who are projected to have dementia. And most of these people, in fact, will live in low and middle income countries. Apart from the high economic costs to countries, the dementia is also a substantial cost to societies, to families and communities, and most importantly, to caregivers. This is compounded by the fact that lack of awareness about dementia increases the stigma and discrimination that people with dementia and their families face. Next slide, please. In order to address this public health threat, we now have the Global Action Plan on the Public Health Response to Dementia, which was endorsed by the World Health Assembly in 2017. Next slide. It proposes actions to governments, civil society, and other global and regional partners across 7 different action areas. Each of these action areas include global targets, some of which are very ambitious. So all of us have our work cut out for us in order to meet this global challenge. Next slide, please. And WHO is also working hard to support countries in addressing these different action areas. For example, we have the policy guide to help countries develop their dementia policies or integrate dementia into their existing policies. I support for caregivers, and the overarching Global Dementia Observatory, which acts as a monitoring and accountability mechanism to see how we're achieving these different targets. Next slide, please. Focusing on risk reduction now, which is the 3rd action area, we are very pleased to have launched just last month the new dementia risk reduction guidelines. And we know that dementia is not an inevitable cause of aging, that there are various modifiable risk factors that are either in, next slide, please. Thank you. These are different lifestyle factors and also factors that increase the risk for non-communicable diseases. Also, certain medical health conditions are associated with increased risk of dementia. The increasing global threat that dementia poses, the fact that there are modifiable risk factors, and the fact that at this point we do not have a curative treatment for dementia makes it extremely important for us to focus on dementia risk reduction. So in line with the mandate of the Global Action Plan, WHO has developed these risk reduction guidelines, and these are based on the latest available evidence and will provide healthcare providers, policymakers, program managers, as well as patients with information that they would need to address their risk for dementia. Next slide, please. The process that we have followed to develop these guidelines is a very systematic process, and it is elaborated in the WHO Handbook for Guideline Development. We have drawn upon the expertise of an international group from different parts, regions of the world, many of whom are on this panel, and I'm sure many of you are also listening in to this webinar. You'll hear more about the process from the other panelists, but the important thing to note is that we have not started from scratch. So we've had different previous WHO guidelines that we've been able to draw upon, such as the MH-GAP guidelines, the Integrated Care for Older People guidelines, the Package for Essential Non-Communicable Disease Interventions, as well as recent systematic reviews that were conducted, including the one published in The Lancet by the Lancet Commission and the National Academy of Sciences Review. We went a step further in the process as elaborated in the handbook, and apart from just reviewing the evidence from literature, what the committee also did was examine the acceptability and feasibility of these interventions, the costs and the resources that would be needed to deliver these, and the values and preferences that different people would have for these interventions and their outcomes. And based on this, we have developed these recommendations. Next slide, please. So, the key recommendations to reduce our risk of cognitive decline and dementia include getting regular physical exercise, not smoking, controlling weight, reducing the alcohol consumption, eating a healthy and balanced diet, and maintaining healthy levels of blood pressure, blood sugar, and cholesterol. Next, please. In the process of developing these guidelines, we identified many research gaps, and Karen will be speaking to these. There was limited evidence for many of these interventions. Next. And for some risk factors such as depression, hearing loss, and social isolation, we did not have enough evidence currently to be able to develop recommendations. Next slide, please. All of these strategies, as you've noticed, do not only reduce the risk for dementia, but also the risk of non-communicable diseases. So it makes intuitive sense that dissemination and implementation of these guidelines is done through channels for non-communicable disease activities, and we are working closely with our colleagues both in WHO offices as well as our other partners towards doing this. Evaluating the impact is important of actually integrating these recommendations, and we will do this through the Global Dementia Observatory. And it's also important to have a process of defining dementia risk scores. And this will allow healthcare providers to be able to identify people who they see who are at high risk and provide them with the information they would need to reduce their risk. Next slide. It's important that along with these individual level implementations, that the environment is supportive. And therefore, it's important for implementation also to be at the policy and country level. And this is something that we need to advocate strongly for. Country-level implementations can include running mass media campaigns to educate the public on the benefit and importance of dementia risk reduction, linking it, as I said earlier, to non-communicable disease programs, training healthcare providers. This is very important to strengthen the capacity of the healthcare system for dementia risk reduction, using digital technology, which now is an emerging field, and how can we use this to address dementia risk? For example, apps for physical activity is one example. And strengthening monitoring efforts also on the prevalence of dementia risk factors and implementation of risk reduction. So basically, in a nutshell, we require targeted investment in dementia prevention, strengthening dementia monitoring, knowledge sharing, and most importantly, to remember that none of us can do this alone. So building partnerships, as we are doing currently, is another very important thing to focus on. Next slide, please. And with this, I thank you again for being present on this webinar.
Thank you very much, Neerja, for this wonderful and very, very clear presentation. I have noticed that whilst we were speaking, quite a few people came onto the webinar, so welcome. You heard Dr. Neerja Chowdhary speaking from the World Health Organization on the newly released risk reduction guidelines. Now I give the word to our second speaker, who is going to be Professor Karin Anstey. Karin, please.
Thank you. Next slide, please. Good morning, good evening, good afternoon, everyone, depending on where you are. I'm going to be talking about some of the methodological aspects of the development of the guidelines, and then we're going to look at the difference between risk reduction and prevention. Next slide, please. Okay, so the guidelines were developed by an international group of experts called the Guideline Development Group, and they assisted the WHO steering group, who also contributed in developing the key questions for the guidelines. A total of 12 PICO questions were developed for the 12 interventions, and PICO stands for Population, Intervention, Comparison and Outcomes. And I'll just run through those. So the population that the guidelines are aimed at are adults with normal cognition and mild cognitive impairment. The interventions are the 12 interventions to reduce the 12 risk factors that we looked at. The comparison groups that we were interested in were care as usual or no intervention. And the outcomes, there were two types of outcomes we looked at. The first were called critical, so that was cognitive function, incident, mild cognitive impairment or dementia. Then we were also interested in things like quality of life and the impact on function, adverse events and dropout rates. However, we didn't find a lot of evidence around those second lot of outcomes. So when the PICO questions were developed for the interventions, the evidence groups worked on these through conducting systematic reviews of the literature, and there were 2 evidence groups, one in Australia and one in Finland. Next slide, please. So how did we get the evidence? There's 3 stages. The first was synthesis. Systematic reviews of randomized controlled trials were graded for their quality of evidence. Where evidence was lacking, we looked at the observational studies, and that was used to give us a more comprehensive picture. And in some of these areas, there is quite a limitation in terms of intervention research. The grading of recommendations, assessment, development and evaluation methodology, which is called GRADE, was used, as well as the WHO Handbook for Guideline Development. And those 2 sources were used to develop the evidence profiles. And the teams had regular communication and discussion with WHO and a grade methodologist, Corrado Barbarino, and we did that by email and teleconference. Then in Geneva in July 2018, the Guideline Development Group met and reviewed the evidence that had been developed, clarified points, interpreted findings, and developed the recommendations which formed the document that's now available. Next slide, please. So that was the process. Now I just want to clarify a question that comes up a lot when we talk about guidelines. And that's the difference between risk reduction and prevention. And I think the simplest way of thinking about this is that risk reduction is what we talk about when we're talking about the individual, that's me or you, and what we have to do to reduce our risk of dementia. When we're looking at prevention, we're talking about a population level concept about, and the easiest way of understanding this, I think, is thinking about smoking and lung cancer. So we all know that if we give up smoking, we reduce our risk of lung cancer, but we may still get lung cancer. So for any individual, we can't say, well, you've given up smoking, so you will not develop lung cancer. But we know if across the population we see a 20% drop in smoking, then we will see reduced lung cancer at the population level. And we would say, a population health approach would say, we have prevented some cases of incident lung cancer by reducing the risk factor at the population level. So when we're talking about prevention, we're tending to talk, it's more at a population health or a policy level, and that's where you're hearing the word. And it's when you're talking about yourself as an individual, we're talking about our risk, reducing our own risk. So there's these 2 terms, and I understand that often people do get confused between the 2, and I hope that's clarified that point for you, but happy to take questions at the end about that. Next slide, please. I just wanted to reiterate some of the research gaps that Neerja mentioned. So there is a limit of information in some areas. There's geographical limitations, so some regions of the world we didn't get information from, and particularly low and middle income countries, but there are also many high income countries where the evidence, there isn't any evidence from intervention studies in particular. A number of the studies that we looked at had a very short follow-up period. So for cognitive training, many of the trials are only a few months follow-up, although we have the active trial, which of course has gone for many years. But when we're looking at exposure to risk, we're thinking about decades. So we're thinking about a person who may have smoked for decades or had a particular diet or physical activity habit for decades. And yet we're looking at intervention studies where the follow-up's only a few months or even a couple of years. So that's a limitation in the literature, which is improving as the studies continue. Another issue is sometimes there's a difference between midlife and late life. So when we've done the long-term studies, so studies that Mia in particular has conducted, we found some of the risk factors are important in middle age and not later life. But then some of the interventions, so in blood pressure, the intervention studies have all been in older adults. And they've shown a reduction of cognitive decline. So those problems and gaps will improve as we follow the interventions longer. the literature that we looked at often didn't distinguish between dementia subtypes, so we're not able to answer very detailed questions on whether specific risk reduction relates to specific dementia subtypes. We're talking at a more general level still. And the good thing to remember, though, is that this is an area where there's a lot happening in terms of research, so there's new information coming out all the time, and some of these gaps will be filled over the coming years. And I think it's over to Mia now to continue.
Thank you very much, Karin. I particularly want to thank you for the incredibly clear slide about the difference between risk reduction and prevention, which so many people ask ADI about all the time, and also to explain to us the complexities and the uncertainties that come from organizing a study of this level. I think for those of you that have joined, and if you've joined in the last few minutes, you just heard Professor Karin Anstey speaking about the methodology of the risk reduction studies, and before then, Dr. Chowdhary explained to us about the methodology and the study itself, actually, and pointing out to us some very important points about how the study was designed to include a new way of looking at the data that included the acceptability, the feasibility, the cost, which had not been included in previous studies. Now, before I pass the baton to Professor Kivipalto in Finland, I'd just like to answer to one of the questions that we have received whilst Karin was speaking, which was whether if the slides will be available after. Yes, we are recording the slides, and all the slides will be available afterwards on our website as per all of our webinars. Thank you very much. Professor Kivipalto, Mia.
Thank you for the invitation. It's very nice to be here today, and sunny greetings from Finland. We are celebrating the Midsummer Eve and the nightless night. So here it's impossible to say if it's night or day. Sun is shining all the time. Next slide, thank you. So the topic is very important. Can we reduce the risk of cognitive impairment and dementia? We can take the next one, please. And I think the WHO risk reduction guidelines are, as said, very timely and very important. The prevention can be seen as the key element if we want to manage the dementia epidemic globally, especially given the increasing numbers, but also the fact that we do not have yet any disease-modifying drugs. I think the guidelines also nicely reflect what we have learned from our research during the last 10 to 20 years. First, we know now that dementia and late onset Alzheimer's disease are very complex, heterogeneous, and multifactorial conditions, as you can see from this slide. There are several interrelated disease mechanisms, and actually it's known that especially among the oldest persons, pure Alzheimer pathology is very rare. Most of the cases have so-called mixed dementia with different kinds of pathologies there. We also know that the process leading to Alzheimer's dementia may take very long time. The first changes in the brain may start to develop 20 to 30 years before we can do the dementia diagnosis. And that's why we really need to have this life course perspective. And we also know that there are complex interactions between genes and environmental factors. Altogether, it has been estimated that around 30% of late onset Alzheimer can be related with these 7 risk factors, which I have listed here. And I think taken together, this gives to us a very nice prevention potential, meaning that there are both different targets and there are different timelines for the interventions. Next slide, please. This list of risk and protective factors we went through with WHO, as you can see, compared to the list of the 7 factors, it's a bit larger. There are also novel risk factors, or at least newer risk factors included, and I think that is very important. We wanted to include factors which have been reported in the recent literature and see how much evidence is available for all of these risk factors. As Kari mentioned, we had very nice workshops and meetings where we tried to go through the literature in a very systematic way and trying to see what are still the research gaps. We can take the next slide. One important area, as mentioned, we have more and more evidence from these risk factors, but the concept of multi-domain intervention is still quite new in the dementia field. And as you will see in this evidence review, these risk factors were treated separately, but this multi-domain intervention was just mentioned. We can take the next slide. And indeed, and we can press once again, what we now know about Alzheimer, these different risk factors, probably we need to target several risk factors at the same time to get an optimal preventive effect. That's what I call for the multi-domain intervention. At the same time, we know that one size does not fit all. In the future, we probably need to tailor the interventions, taking into account individual risk profiles. And as Kari mentioned, we need to identify the optimal time windows because the risk profiles and the importance may be different if we are talking about midlife persons and if we are talking about late life persons, if we are talking about the general populations of persons who already have mild cognitive impairment. Next slide, please. One lack in the evidence was indeed randomized controlled trials. We do not still have very many positive findings from these trials, and FINGER is one of these, or is the first large multi-domain lifestyle-based intervention showing that this lifestyle package, where we are targeting several risk factors at the same time, can indeed reduce the risk of both cognitive and functional decline among at-risk populations. Neerja mentioned the importance of risk scores and finding the at-risk individuals. In the FINGER trial, we used the GATE dementia risk score, trying to identify the persons who had modifiable risk factors when we started the trial. This intervention was 2 years, but as Kari mentioned, it would be wonderful to get more this long-term follow-up data. And we have actually now already 7-year data available from FINGER. And I hope that we can have also the 10-year follow-up, that we can really learn more about the long-term effects of this type of intervention. Next slide, please. One aspect I would like to highlight from FINGER was really this social engagement. That was not a separate part of the intervention, but that was part of the intervention package, meaning that we used both group and individual training. And the feedback we got was clear. People really appreciated having this social interaction, and they got extra motivation when they met other people. Next slide, please. FINGER is now used as a model globally when there are these new trials starting. And to support these new trials, we have started the worldwide FINGERs network. And I'm very happy to tell that now more than 20 countries have joined this intervention and this initiative, starting testing and adapting the FINGER concept in different areas. These countries, which you can see here with dark blue, are the countries who already have ongoing or at least close to ongoing intervention there. And these with lighter blue are countries which have just joined. As an example, in Latin America, there are 9 countries now joining, and they have LAT and FINGER as a consortia, really aiming to be part of this initiative. Next slide, please. One key aspect in the worldwide FINGERs is the harmonization. One research gap in the worldwide, in the WHO guidelines, and what we found was the lack of harmonization when it comes to exposure and outcome measures. So here we hope that we can try to harmonize the methods before the trials are started. So it's like one hand and the fingers. We aim to harmonize, but there needs to be local adaptation for each of these intervention components and outcomes as well. We also hope that worldwide FINGERs can help in the implementation. Here, all stakeholders, all hands and fingers are indeed needed. And then my last slide. where I would also like to highlight, as Neerja mentioned, the possibility when we are using new technology to facilitate personalized, effective, and feasible interventions and implementation. For example, the e-health and m-health would help in self-management, spreading the information, in self-monitoring and follow-up. So I really hope that we can start using it more and more. Thank you.
Thank you very much, Mia, for this wonderful presentation. You also have answered one of the questions that have come through in the meantime, which was that there was little evidence from lower and middle income countries. Is there an ongoing research project? As you have now just demonstrated to us, with so much of Latin America now joining FINGER, definitely there will be. However, I would like to prompt whomever is listening to us today, if you are in a position to be influencing whether your country joins a study such as FINGER's, please do get in touch with Professor Chivipelto, write to us and we can put you in touch, because FINGER is growing and is hope. FINGER is hope. We are all hoping that this wonderful project will tell us a little bit more, a lot more, about what culturally is appropriate in each of our countries, with a certain higher certainty. And actually, Mia, I also have another question that I'll ask you briefly before we pass to the proper Q&A. There is a question here about whether there is other multi-domain intervention research apart from FINGER globally. Can you tell us a little bit more whether there is any?
There are surely several trials using different kind of multi-domain studies, and we are trying to increase the knowledge what is going on in different parts of the country, and we are trying also to have different levels in the worldwide fingers. The goal is that the new trials, we try to harmonize the outcome measures and interventions, but then there are also other trials who may not be able to use the same outcomes, and they can be associated studies, so that still at the end we can try to pull the data or at least do some comparisons. That has been the challenge in many of the trials, that the power is sometimes too low in single studies or single countries. So that's what I see as the power of worldwide fingers, that we aim to harmonize, we aim to share experiences and data, so that not new countries do the same mistakes what we have learned. So really sharing the lessons learned. But yes, there are surely studies which we are not yet aware of, but we hope that we can increase the knowledge between all countries. And I would really hope that the map which I showed, there are still white areas. So I hope next year, this time, the map is more blue.
We all hope so, Mia, and thank you so much. I will now pass the baton to the wonderful Kate Swaffer, who, just to remind those of you that arrived late, is the CEO and founder of Dementia Alliance International. Kate, please.
Thanks, Paola, and good morning, good afternoon, good evening, or welcome. It's lovely to be here. Thank you for the invitation. Next slide, please. So that's just highlighting the need for risk reduction, I guess. Next slide, thank you. So I think I'll speak from the perspective of specifically people with dementia and their families. The potential to reduce the economic and human costs to people with dementia and their families. If not now, then this risk reduction focus will certainly do well for us in the future. There's been emerging evidence for some years, and we're really pleased that the WHO have put together a team to create this risk reduction guidelines for us. Risk reduction, a lot of people living with dementia have, because there's no treatment for most of us, and for many there's no medication at all, healthy lifestyle has been one of the ways that many of us have decided to manage once we've got dementia, and I think that the risk reduction evidence is going to really change what happens for people with dementia and their families in the future, or people at risk of dementia. Karen, I too was really, really pleased with your relatively easy to understand distinction between risk reduction versus prevention, because people with dementia and their families get very, very upset about the use of the word prevention, because they think that the risk reduction factors are going to prevent them or their families getting dementia. So there's been a lot of angst amongst the population of people with dementia about the use of that term prevention. And I think we could do with a bit of a campaign about the difference between risk reduction and prevention. Next slide, please. So the topics really interest people with dementia because even if, for those of us already diagnosed, even if they're not a cure, even if they don't reduce or slow down the progression of dementia, things like reducing blood pressure, reducing our cholesterol if it's high, reducing our risk for obesity, for diabetes, losing weight if we happen to be overweight, increasing exercise. If nothing else, that increases our well-being, and it reduces the impact of a lot of the other NCDs or other comorbidities. So it supports some of the emerging evidence of reversing or slowing the progression of dementia. And I think for people with dementia and their families, it gives us hope for a sense of hope. I'm sorry, I've got a cat about to jump on the keyboard. Totally lost track there. So I think that the risk reduction evidence is actually supporting what many of us with dementia are already doing, which may or may not slow down the progression, but certainly increases our health and reduces the risk of many other comorbidities. Next slide. So that's really all I've got tonight. I'm sorry I'm a little bit overtired tonight, but thank you.
Thank you very much, Kate, for joining us from Australia, like Karen, and showing incredible commitment to the cause. And I hope your cat eventually will find the right way to get on the desk.
Just jumped on my lap.
Thank you so much. I have got quite a few questions here, and it's very exciting to see the level of engagement that we have had. Now, bear with us. Some of these questions are very technical, and some are very simple. The first question I think I'm going to start with is a question that I would like to ask Kate, as she's been the last panelist that spoke to us. And this is, can you slow, Kate, cognitive decline by taking on some of the good habits recommended in the risk reduction guidelines?
Well, I can't say what the evidence would say to that, Paola. I can certainly say from a case study of one myself, I think that having adopted many of the risk reduction strategies 9-10 years ago, as well as adding in brain injury style rehabilitation, and also adding in new learning, I think that I've slowed the speed of the progression of my dementia. Clinically, it still shows some deterioration, but my functional capacity has not progressed as predicted. So I think that as a case study of one, and I think when you look around the world at many of the other advocates who have adopted a similar approach to dementia, and I think, as someone said earlier, even though there's not evidence for socialisation being a strong enough factor to put in the guidelines, staying socialised as opposed to being isolated and staying at home and developing things like depression certainly has to improve people's quality of life, if nothing else.
Thank you very much, Kate. That is why it's so important. It may be a case study of one, but you are living with dementia, so no one more than you would know what it means not to have taken those recommendations. And to continue on that line, Neerja, this is one for you. Somebody asked, what are 3 things I can do right now to reduce my risk for dementia? What can I take away and change after this webinar? Although we don't know what that person is doing in the first place, so you'll have to do a bit of guesswork there.
Thanks, Paola, and thanks. That's a really lovely question. If I was to think of 3 things that you could do right away, do and don't do, that is. So you can exercise more, you can eat a healthy and balanced diet. You can stop smoking and taking alcohol if you're taking these. And the third thing is have a regular checkup, see your doctor to check if you have any of the physical health conditions such as elevated blood pressure, blood sugar, or cholesterol levels. And if you have these, then to take treatment for them. I hope that answers your question.
Thanks, Neerja. It certainly does. 3 simple things that we can all do. They're so difficult to do, but we can all do. Karin, the next one is for you. Somebody is asking, I'm in my mid-50s. Is it too late for me to start reducing my risk? Has the damage been done? You told us a lot about the criteria with which this study was conducted. So what can you tell us about that?
Well, there is a lot you can do in the mid-50s. A lot of those interventions that we used for the evidence were on older adults, and the finger study that Mia is leading is on older adults who are from 60 or 65 and older. So it's never too late. We've seen benefits with people in their 80s, 90s who've taken up physical activity, and we've even seen people in nursing homes who've adopted some of these lifestyle changes and had their vascular risk factors managed better show improvements as well.
Thank you very much, Karin. Mia, you've got the next one, which is a very important question. And so we are moving now a little bit into another area of the questions. There is a number of groupings, so I'm trying to follow the groupings. Can Alzheimer's disease be diagnosed at around age 20 or 30 as a first case of early onset Alzheimer's disease without any known case in the family or blood relatives of such a patient? There are a few questions that come in around the genetics of Alzheimer's.
Yes, that's a very good question. And yeah, there are cases. It can be the first case in the family. There may be some mutations not yet known or undiagnosed dementia in a little bit more further in the family. So the answer is yes. In general, if we comes to the genetics, and Paola, you mentioned that there were also some other questions. So we know that there are these familiar cases of Alzheimer's disease, but actually around only 1% of those who have Alzheimer have some known mutation. So it's still very little part of all Alzheimer cases who have the known mutation. And then the age of onset can be very early. It is normally around 40, but it can be even younger. And what is the role of lifestyle factors when you have this mutation is not yet fully understood.
So more research is needed, and this is why it's so important to continue to back up for all governments out there that 1% of the societal cost of the disease, which as we know is huge, is devoted to research, because only through research we will find a solution to what is such a big crisis. Now, Neerja, actually no, Mia, there is one follow-up question directly related to your presentation. Somebody has asked about the risk scores slide that you presented. Can you share more information on how you got the scores?
Yes, that is based on our publication in Lancet Neurology 2007. I'm happy to share that as well. So it's based on an algorithm, how we calculated the risk factors. As you could see, we wanted to include only quite simple risk factors people normally know, meaning age, education, sex, blood pressure, cholesterol, and physical activity. And then you got the score based on beta coefficient. So it's a kind of algorithm there. That score is for midlife. Now we are expanding, we are developing score for different age groups, because as I mentioned, the importance of risk factors may vary if you are at midlife or later in life.
Thank you very much. Neerja, it's your turn one. there are quite a lot of questions that goes to the core of the actual report. So I'm going to take some of them, and if you get tired to answer them, you may want to dish them out to some of your panelists as well. Now, one of the questions which is really at the core of the report is, are there different research findings in high resource versus low resource settings? So I think we're talking here of higher income countries versus low income countries. Have you seen any sensible difference, given that we know that in lower income countries the incidence of dementia is actually going up?
Thanks, Paola, for the question. And I am reverting now to Karen's slide on research gaps. And I think it's difficult at this point for us to conclude if there are actual differences in effectiveness of these interventions in high income versus low income countries, just for the very reason that the evidence from low income countries is really small. So we don't have enough studies for us to be able to actually do these subgroup differences and compare these findings.
And so for everybody out there, once again, if you're listening to this and you have an opportunity to influence your country to actually enter in one of the studies, that is the best way that we will get to know whether anything can be changed in the way that these are influenced. And I think we should bring back also to what Mia was saying, that a lot of the finger study has to be culturally specific to any particular country. So we know people talk about specific diets, for example, those varies wherever you are in the world. So things have to be accessible. I think what Neerja, you said earlier about the fact that you considered accessibility as well. There's no point in telling a country go for this diet when they don't actually have the primary elements that would allow them to access that diet. Now, Neerja, there are a couple of questions here that you may want to get a little bit more under the skin of. There is people asking, did you look at anything related to pollution versus dementia? This is something that is gaining quite a lot of traction. Similarly, there are people that want to know a little bit more about the impact of hearing impairment. Sorry, I'm Italian, H's are a real challenge for me. Hearing impairment to the incidence of dementia. And I think I will leave you with those two. So pollution and hearing impairment to start with, then we pass to the others. Thank you.
So yeah, thank you, Paola. There are other risk factors which have been identified apart from these 12 that we studied for the scope of these guidelines. And for example, air pollution was one of them that we did consider to include. However, there is not enough studies to show that there is any change that we can find and there are no intervention studies on this. So we've not included them in the scope of these guidelines. What we've done is focused on the ones where at least there would be some evidence for us to be able to provide some recommendations. We do know that now there are studies that have reported air pollution and its effect on cognition and the incidence of dementia. And we will be watching for more of this as it emerges. The other question was about hearing impairment. Yes, yeah. Hearing impairment is a well-established risk factor for cognitive decline and dementia. And that's why we did include that within the scope. However, when we did the reviews and we looked at the evidence, the committee felt that at this point in time, the results from the studies were conflicting. There was not enough to definitely conclude that, yes, we can reduce our risk of dementia by addressing hearing impairment. However, the WHO recommends that that older people do get assessed for hearing and are given hearing aids. And this is also what is recommended in the ICOPE guidelines that I mentioned earlier, the integrated care for older people. So yes, this is important. At this point in time, it's not, we don't know enough to say whether this will also reduce the risk of dementia. But let me also say that there are many emerging studies in this field. There are many ongoing studies that are looking at this, and we will be watching to see what the results of these studies show.
And actually, as Karen said, some studies have been published right now. Perhaps, Neerja, you will be able to tell us at what kind of frequency, every year or every 2 years. I'm sure you will do a review of these guidelines, no?
Usually the guidelines are for about 3 to 5 years. And as evidence emerges, we do update them. Of course, if there's some important evidence that we feel needs to be incorporated, we need to look at more closely, we will do that in between too.
We've had here a very interesting and quite complex question, which I'll try and summarize. It came with a lot of information. And it's about the vitamins B, E, and multi-complex supplementation. I think the question is whether the panel would agree that a fundamental concept in nutrition is that no benefit of supplementation with a nutrient would be expected in the state if the status of the nutrient is already optimal. And I think this came because there was confusion in the guidelines on whether the guidelines essentially are neutral about vitamin B and E. But the point was, have you considered whether people are deficient in these vitamins, which I'm sure you have, but I just let you answer the question because you've seen it and it was quite complicated.
Yeah, so Karen defined to you how we've addressed the population, intervention, control, and outcomes when we've done these systematic reviews and looked at the evidence. When we've looked at evidence for supplements, vitamins, etc., in reducing the risk of cognitive decline and dementia, the evidence shows that there's nothing to suggest that these actually are beneficial in reducing dementia risk. In fact, another factor that also the review committee does in providing recommendations is weighing the benefits versus the harms of these interventions. And there's evidence to show that, in fact, high doses of some of these supplements can be more harmful. And therefore, in fact, the guidelines make a negative recommendation saying that these should not be used for reducing the risk of cognitive decline and dementia. About the use of these vitamins and supplements in people who have deficiencies, it is beyond the scope of these guidelines, and that's why we've not included that population here, and that's why we've specifically mentioned in the guidelines that this recommendation is for people who we presume do not have deficiencies, and with people with deficiencies, of course, there might be different recommendations, but it's beyond our scope.
Thank you very much. And also to explain more clearly what was the scope of the study. This study specifically looks at dementia. And so obviously one would expect that it would be taken in consideration with other studies that look obviously at wider nutritional deficiency in any given population. So thank you very much, Neerja. Now, Kate, the next one probably would be quite interesting for you to look at, and perhaps Neerja, you may want to supplement that. The question is arrived today around whether social activities could help. Is this actually evidence-based? Kate, you mentioned that earlier in your intervention, and we know how important that is.
Yeah, well, I don't know enough about the evidence for whether social engagement reduces the risk of getting dementia. But I certainly know that once you've got dementia, the studies into loneliness and isolation and stigma once people are diagnosed with dementia, it's still such a significant experience for so many people living with dementia. If we're able to maintain a good social and other lifestyle, then, there's so many benefits beyond just well-being. And I have a question actually for, seeing as I've got three of the experts here from the WHO who've worked on these guidelines, something that's been emerging in comments, either direct comments to me through email or in private Facebook support groups of people with dementia or family care partners. There seems to be this emerging feeling that they're going to be blamed for getting dementia if they haven't taken on all of these risk reduction strategies. Have you got any comments about that you could make? There's that sense that, well, if you got dementia, it's your own fault because you didn't follow all of those risk reduction strategies.
Perhaps, Karin, would you want to comment?
Yeah, I'll have a go at it. I think it's a really fair concern, and of course, it's kind of like a miss. It's not what the evidence is saying either, and it's kind of like an interpretation, and it's not or helpful to say that. But I can see how people could worry about that. So I think I just go back to the smoking and lung cancer example. We know some people get lung cancer who've never smoked, And we know
exactly.
don't get lung cancer, but we also all know it's good that we give up smoking to reduce our risk of lung cancer. And it's the same with these lifestyle behaviours. We know that it's the best thing we can possibly do. And some people will still develop dementia for genetic reasons, all sorts of other reasons. And some people who don't do the right thing won't develop dementia. So it's not black and white. You have to learn to live with is that uncertainty.
Yeah, I know certainly a lot of people who develop type 2 diabetes that I know in my own circles often get blamed by family members for, poor lifestyle, serve yourself right. Yeah. So there is a bit of a worry for people with dementia as well. We don't want the risk reduction evidence to increase the stigma.
No.
Not at all, no.
And Kate, we also have to look at the fact that in the cancer community, there's been a lot of that.
Exactly.
People have been feeling guilty if they're not fighting back after contracting cancer, which, as we know, may not be, may be detrimental to their mental state as well as struggling with such a complex disease. So I've got quite a few questions. I'm going to take a couple myself quickly before passing a really good one to Neerja. So one is whether there will be any communication materials developed by WHO and ADI that they can use in their country. And the answer to that is yes. Part of what we are trying to do as well is to update our infographics so that we will come with a revised version that will include all of these recommendations that then people can use in their country in the usual, simple, very easy to understand way that ADI is famous for. The other question that I wanted to pass to Neerja was, you will like this because you're doing something about this right now at WHO, and I know that. They want to know how can people outside of universities or the WHO feed new ideas into the risk reduction program?
Thanks, Paola. Let me also, before answering this question, go back to your question about communication material and information material. Also to say that already on the website, we do have a set of posters for risk reduction. These were developed by our WHO office in the Western Pacific region, and they're available for use. They can be easily adapted and used across different regions as needed. The other question was, sorry, Paola, can I ask you to repeat that?
Yeah, sorry, and I'm reading more questions. We got questions all over the place. So it's great. So the question was, how can people outside of universities and WHO feed the new ideas into a risk reduction program? I know that you have your new platform to encourage more participation. That consultation is still open, isn't it?
So I did mention the Global Dementia Observatory earlier. Now this is both a data platform as well as a knowledge exchange platform. So we are going to have a lot of information available on the platform of different, for example, case studies and good practices that people have used in different aspects of dementia, not only risk reduction, but also care interventions that we're using, or dementia awareness raising activities, for example. And we will be opening this out for contributions from everyone. So you can submit your resources here. We will have a panel of panel who will review these resources, and then we'll have them uploaded. So yeah, thank you for that question. And we'll have this ready for you soon.
Thank you. We only have 2 minutes left. I'm going to ask a question to the whole panel, and then you may decide who answers this. This is a very interesting question. How can we balance encouraging behavior change against not placing too much emphasis on personal choice and responsibility? It's connected to the question that Kate mentioned earlier, that is talking about how can we balance basically a regulatory environment, a state that controls the individuals, versus the own responsibility of the individual. And I have to say, I find it very interesting because I have also found different attitudes to these questions in different countries that I have visited. So can we open it more broadly? Mia.
Yes, a very good question and short comment. I think I totally agree. We should try to make the societies not only dementia friendly, but dementia prevention friendly, making the healthy choices the easy ones. We have examples from Finger that, for example, the gym, physical activity, the knowledge and understanding about diet, individual needs to get support to make it these choices. So it's not only individual choices, it's the society, it's the community that needs to be there. And I would also like to further highlight the importance of this communication, risk reduction, and not giving a negative flavor that is someone's fault if you could get if you get dementia. So I would more like to talk really about risk reduction and having the positive kind of message that you don't always maybe can stop the disease or prevent, but postponing the onset. Instead of getting it when you are 65, maybe you get it when you are 70. That would be a huge impact for the individual and for the whole society.
Thank you very much. Very good answer. Anybody want to jump in? No, you can't. Actually, this was our allotted time. So let me wrap it up by saying thank you so much for my wonderful panelists and also for all the work that they have put into this great report by ensuring everybody on the line that we will be coming up with a renewed infographic for our members. WHO also has materials already available that people can download straight away around this. Also, please bear in mind that we will endeavor to answer in writing all of those questions that have not been answered, although the panel did take many. Thank you, all of you that have been following us from wherever you are, and for the way that you have engaged. And I hope that you have found that the subject matter interesting. Continue to log into this debate because things will change, as we know, hopefully more in the future. Thank you, everyone.